Dear viewer, good afternoon, good morning, and good evening. My name is Amos Kiptoo. I'm the resident of specialist St. Luke's Orthopedic and Trauma Hospital. It is yet another opportunity that God has given us, and we want to discuss eye conditions with regards to ophthalmological series we are here to present today. Welcome, enjoy, and if there is any question, please leave a message and subscribe to our channel. Thank you. As promised, today we are doing ophthalmology series part 2, and we are discussing an overview of a disease called glaucoma. And my name is Amos Kiptoo. I'm the resident eye specialist at St. Luke's Hospital in Hello. So I will quickly mention a few things that we need to know about our eye. As you can see, this is our eye. This is the eyeball. And this is the front part of the eye. This is where we call the cornea, and this is the retina. The normal eye needs to be firm, not to be like a sponge. So we have something called the flow of the aqueous. For example, of a ball, for a ball to maintain its shape, it has to have a pressure inside. So with eye, the same also applies. So there's something called aqueous humor that enables the eye to maintain its shape. And today we want to see where it produced and how it flows. So for instance, it is produced here where we call a ciliary body, and it follows this arrow all the way from this point. You see there's a lens here, the aqueous humor flows all the way to the conjunctiva through two different pathways. So while we are discussing about the glaucoma, it is a condition that it's a group of conditions, eye conditions, that involves a chronic progressive optic neuropathy that results in changes in the optic nerve head and retinal fiber layer. So as we said, for the ball, it has to have a pressure. So eye has to have a pressure within normal limits. And if it goes above the normal limits, it causes what we call glaucoma. And the condition itself causes irreversible blindness. So we have classifications of glaucoma. And we'll start with primary, move to secondary, and insist on primary. We have secondary, we have childhood glaucoma. So for an adult, we have something called a primary open angle glaucoma, normal tension where there is the pressure of the eye is within normal limits, but it causes changes in the optic nerves. We have ocular hypertension, the pressure is high, but it does not affect the vision, because when we talk of glaucoma, we are referring to changes in the visual field and high pressure, and also depending on the site. So we have something called plateau. This is more complex, but I will mention primary open glaucoma today, and childhood glaucomas. So even children who are born can have glaucoma. People who are adult can have glaucoma. So as I said, we discussed the primary open angle glaucoma, abbreviated as POAG. It is a chronic, progressive that keeps on causing damage to the nerves, and for a long time, because it's called chronic. And the angle, let me show you the angle. The angle is this part. It is opened. So once it is open, then the aqueous humor flows. So it is an open angle glaucoma. It is characterized by changes in the optic nerve disc, which we call it a damage. We will see that at the end of the presentation, and causes visual field loss. So as you sit or stand and look in front of you, that is the field of vision. And when we say there's a damage in that field of vision, that means if you're looking forward, you might not see what is besides you, both on the right or the left. and it has the degrees that I will present in the near future about glaucoma. And the angle at the anterior chamber is open. We will see risk factors. What are some of the risk factors with regards to primary open angle glaucoma? We have someone who is age above 35 has high risk. Someone who has high intraocular pressure. The pressure that I'm still referring to the bone. Then the eye has to have high IOP. So if it is high, we call it high intraocular pressure. By default, African race is also a risk factor. And genetics, that brings about family history of glaucoma. In a patient who has a short-sightedness overpower more than 4 diopters, has a risk of developing glaucoma. In a patient also with a very thin cornea, I can show you where the cornea is. The cornea is this front part of the eye. So once the thickness from this point becomes thin to that region, assuming this line moves here, it becomes thin. So this client or patient has high risk of glaucoma. We have had people mention migraneous headaches. Migraneous headache is associated with hypotension that causes insufficient blood supply to the nerve. Also in a patient with hypotension as by itself, that is diastolic pressure of less than 55, has risk of developing glaucoma. We have other conditions like obstructive sleep apnea, condition of the eyes, which is called pseudoexfoliative syndrome, pigment dispersion syndrome. These are the conditions that we find it when we examine the eye. Of something to mention is a patient who has diabetes. Diabetes is associated with a glaucoma called neovascularization glaucoma that damages the optic nerve. A patient with other conditions of the cardiovascular system, that is the heart conditions, have high risk of developing primary open angle glaucoma. What do you do? What do we do when we have this client? We examine, we check the visual status of the eye. We do something called visual acuity. So we check ability of this patient to be able to see as part of the signs and symptoms. And in most cases, the patients might be seeing well or completely blind because a disease that does not have any pain, you see. And the effect of this disease causes irreversible blindness. That means the patient will wake up one day and repose no vision at all. We examine the pupil. The pupil plays a very important role in ophthalmology. And once we check the pupil, we are able to examine something called relative afferent pupillary defect, which shows that there is a disease in the retina. Sometimes we do color vision because the patient might have lost color between the red and green. So we check the color vision using our Ishihara chart testing. Of importance after that is we do what we call slit lamp examination. We examine the eye. We check that if there are features of glaucoma, if there are features of secondary form of glaucoma or primary causes of glaucoma. And after that now we measure the intraocular pressure through a procedure called tonometry so that we check the pressure. So we examine you. Once you come to the eye clinic, we check the pressure. We also do a slit lamp examination where we examine the ankles through a procedure called conioscopy. As you can see, this procedure is done with in conjunction with this slit lamp examination and tonometry at the same time. And then what do we see? As you can see, this is when I'm examining a patient, when I was examining a patient using a slit lamp. This is a machine called a slit lamp. And sometimes during an outreach missions, we do have this machine to see the nerve. So here we do the slit lamp examination. We do also conioscopy to see the ankles, if they are open or closed. Also to see the status of the eye. Equally, this one is a direct ophthalmoscopy. We examine the nerve. So these are some of the things that we examine. One, for a normal nerve, you can see this is the optic nerve. And this is the disc, and this is the cup. So we examine to call cup disc ratios. If the ratio of the disc with the ratio of the cup with regards to the eye, with reference to the eye is higher, then we suspect glaucoma. For instance, look here. This is the cup, and from this point to that point, and from this point to that point is the disc. So we check how many times does the cup fill in the disc during that slit lamp exam. And in glaucoma,